The grand ballroom of the Meridian Hotel sparkled with medical excellence as St. Catherine's Hospital hosted its annual Heart Foundation Gala, celebrating another year of cardiovascular breakthroughs and life-saving innovations. Crystal chandeliers cast warm light over tables filled with the region's most respected cardiac specialists, nursing administrators and hospital board members, all gathered to honor advances in heart disease treatment and research. I sat at table 12 in a black evening gown carefully chosen to hide the surgical scar that ran down my chest, listening to my mother hold court among her nursing colleagues about the importance of patient advocacy and family support in cardiac care. The mechanical valve in my chest clicked with each heartbeat, a sound that had become my constant companion since my surgery 6 months ago, but which my family had learned to ignore with practiced expertise. Patient education is so crucial, Mom declared to the circle of cardiovascular nurses surrounding her, her voice carrying the authority of someone who'd spent 20 years managing cardiac ICU protocols at St. Catherine's. Families need to understand the difference between genuine medical emergencies and routine procedures that patients sometimes dramatize for attention. The irony of her statement wasn't lost on me. As director of cardiac nursing, Dr. Patricia Williams had built a reputation for clinical excellence and patient advocacy that had earned her recognition throughout the medical community. Her expertise in post-surgical care had saved countless lives, and her leadership had elevated the hospital's cardiac program to national prominence. What made the evening surreal was that she'd spent the past year systematically dismissing the cardiac emergency that had required my emergency valve replacement, treating my life-threatening condition as routine medical maintenance while accepting praise for her expertise in exactly the same type of cases from colleagues who had no idea she'd nearly let her own daughter die from cardiovascular negligence. "Mom's absolutely right," added my younger brother Dr. Kevin Williams from his position near the dessert table, where he'd been discussing his cardiothoracic surgery residency with attending physicians who might influence his career trajectory. Some patients interpret standard cardiac procedures as major medical events, when really they're just routine interventions. Kevin had matched into the most competitive surgical residency program in the region, following in our family's tradition of cardiovascular excellence. His surgical skills were already being noticed by senior attendings, and his future as a cardiac surgeon seemed assured. The respect in his colleagues' voices was earned. Kevin had demonstrated exceptional technical ability and clinical judgment that made him a rising star in cardiac surgery. Except when it came to recognizing that his sister had been dying from acute mitral valve failure for months while the family dismissed her symptoms as anxiety-related cardiac complaints. "The Williams family has such a strong tradition in cardiac care," observed Dr. Margaret Foster, the hospital's chief of cardiovascular nursing, as she joined our table. "Your expertise spans generations. It's inspiring to see how medical knowledge passes through families." "We've been blessed with opportunities to serve," Mom replied with practiced modesty, accepting recognition for medical expertise she'd somehow failed to apply to her own daughter's cardiac crisis. Understanding heart disease requires both clinical knowledge and emotional intelligence. Some people respond to cardiac symptoms with appropriate concern, while others tend toward medical anxiety that can complicate treatment. My medical anxiety had included symptoms like chest pain during minimal exertion, shortness of breath when climbing stairs, and episodes of near fainting that had started 8 months ago. But to my cardiac nursing family, these were signs of psychological stress rather than the mechanical valve failure that eventually required emergency surgery to prevent my heart from stopping completely. "Emma's been our family example of cardiac anxiety," Kevin added helpfully, gesturing toward me with the casual confidence of someone who'd never bothered to actually examine the patient he was diagnosing. "She's been having what she calls heart episodes for months, but when we finally convinced her to get proper evaluation, it turned out to be routine valve maintenance." The description of my emergency mitral valve replacement as routine valve maintenance was so medically inaccurate that I wondered how Kevin had managed to pass his cardiac surgery rotations while maintaining such fundamental misunderstanding of valve pathology. But correcting their public narrative about my minor procedure seemed pointless when they'd already convinced themselves that emergency heart surgery was equivalent to routine medical maintenance. Tomorrow, their cardiac surgery colleagues would learn exactly what routine valve maintenance looked like when someone with actual expertise in cardiac pathology explained the difference between minor valve repair and life-saving emergency surgery. Tonight, I'd let them enjoy their last Cardiac Foundation Gala as the cardiovascular experts they'd never actually been when it came to their own family. The week following the Heart Foundation Gala continued with the same disturbing pattern that had characterized my family's response to my cardiac emergency for 8 months. Mom returned to her morning rounds in the cardiac ICU, monitoring post-surgical patients with the clinical expertise that had made her a leader in cardiovascular nursing. Kevin resumed his cardiothoracic surgery rotations, performing complex cardiac procedures under the supervision of attendings who praised his technical skill and diagnostic acumen. Yet neither of them had bothered to read the post-surgical care instructions that Dr. Harrison Mitchell, the hospital's chief of cardiac surgery, had provided after my emergency valve replacement. "Emma, you need to stop calling me during surgery prep about follow-up appointments," Kevin said during one of his rare phone calls between surgical cases. "I'm learning to repair hearts professionally. I can't drop everything every time you have anxiety about routine postoperative checkups." The routine postoperative checkups he was dismissing were critical monitoring sessions for mechanical valve function that required precise medication management and regular cardiac imaging. But explaining the complexity of mechanical valve maintenance to a cardiac surgery resident who'd already decided I was prone to medical anxiety seemed futile. "Besides," he continued, "if there were genuine concerns about your valve function, don't you think Mom would have noticed? She's been managing cardiac patients for 20 years. She knows the difference between normal post-surgical recovery and actual complications." The irony that Mom's cardiac expertise somehow didn't extend to recognizing mechanical valve dysfunction in her own daughter was lost on Kevin. She'd been so focused on maintaining our family's reputation for cardiac excellence that she'd stopped applying clinical judgment to situations that might complicate that narrative. "Your brother's absolutely right," Mom agreed during our weekly family dinner, where I'd been trying unsuccessfully to discuss my ongoing cardiac monitoring needs. "You've been fixated on this heart surgery for months now. At some point, you need to trust that we understand cardiovascular medicine better than you do and stop seeking attention through cardiac drama." The accusation that I was seeking attention through cardiac drama might have been offensive if it weren't so absurdly disconnected from the reality of living with a mechanical heart valve while my cardiac nursing family planned social schedules around dates that conflicted with my cardiology appointments. "Emma," Dad added with the gentle authority he'd perfected through decades of family medical practice, "anxiety after cardiac surgery is very common. Your mother and I have discussed your situation with several cardiology colleagues, and we all agree that psychological intervention might be more beneficial than continued cardiac monitoring." The revelation that they'd been discussing my psychological condition with cardiology colleagues while ignoring communications from my actual cardiac surgeon made my mechanical valve click more audibly. They'd been undermining my credibility throughout the cardiac community while remaining completely ignorant of the ongoing medical management my condition required. "Dr. Roberts in cardiac psychology has offered to evaluate you," Mom continued helpfully. "She specializes in post-surgical anxiety and could help you understand why you're interpreting normal cardiac recovery as ongoing medical crisis." The suggestion that I needed psychological evaluation for having mechanical valve monitoring needs was so medically negligent that I found myself wondering if my family's cardiac licenses would survive the eventual revelation of their clinical failure. "What about the anticoagulation monitoring?" I asked quietly, making one final attempt to penetrate their willful ignorance of my medical needs. "Have either of you reviewed my INR results or medication adjustments?" The silence that followed revealed the depth of their disconnection from my actual cardiac care. Mom's expression suggested she'd forgotten that mechanical valves required anticoagulation management. Kevin looked genuinely confused about why blood clotting parameters would be relevant to what he'd characterized as routine valve maintenance. "Sweetheart," Mom said finally, "if your anticoagulation needed adjustment, your primary care doctor would handle that routine medication management. The fact that no one has called with urgent concerns proves that your cardiac status is stable." What she didn't know was that Dr. Mitchell had been trying to reach her about critical medication changes for 2 weeks. My cardiologist had left multiple messages about INR monitoring that could prevent stroke or valve thrombosis. The hospital's anticoagulation clinic had been waiting for family consultation about my complex medication regimen. But Mom's voicemail was full, her email was unmonitored, and her assumption that stable cardiac status required no ongoing management had prevented her from learning that mechanical heart valves demand lifelong medical supervision to prevent sudden death. Tomorrow, her cardiac surgery colleagues were going to provide some education about how mechanical valve maintenance actually works. The St. Catherine's Hospital cardiac conference room filled with the region's most respected cardiovascular specialists as Dr. Harrison Mitchell, Chief of Cardiac Surgery, convened an emergency meeting about professional standards and patient care protocols. My family sat in the front row, summoned for what they believed was a routine presentation about post-surgical care advancement in cardiac nursing and surgical training. "Thank you all for attending," Dr. Mitchell began, his voice carrying the gravity of someone who'd performed over 3,000 cardiac surgeries during his 25-year career. Today's case review addresses a situation that has raised serious concerns about professional responsibility and family medical neglect among our senior cardiac staff. Behind him, the large presentation screen displayed the hospital's cardiac surgery logo and the title, Case Study, Professional Negligence in Family Cardiac Care. Mom straightened her nursing uniform, assuming the presentation would focus on someone else's clinical failure, while Kevin checked his surgical schedule for afternoon procedures. Dr. Sarah Chin, the hospital's chief of cardiology, approached the podium with documentation that represented months of failed communication attempts. The case involves a 29-year-old female patient who presented with acute mitral valve regurgitation requiring emergency mechanical valve replacement, a procedure with significant ongoing medical management requirements. She clicked to her first slide. My pre-surgical echocardiogram showing severe mitral valve failure that any cardiac professional would recognize as immediately life-threatening. The imaging was unmistakable, a valve so damaged that survival without emergency surgery would have been measured in weeks, not months. Mom's confident expression began to crumble as she processed imaging that her cardiac nursing expertise forced her to understand. Kevin's surgical training made it impossible for him to deny the severity of what he was seeing on the screen. The patient, Dr. Chin continued with clinical precision, experienced symptoms for 8 months before emergency intervention. Chest pain, exercise intolerance, and episodes of near syncope were consistently dismissed by family members as anxiety-related cardiac complaints rather than mechanical valve failure. She advanced to the next slide, a timeline showing my medical consultations, emergency room visits, and diagnostic testing that painted a picture of progressive cardiac deterioration ignored by family members with cardiac expertise. However, Dr. Mitchell interjected, the patient's immediate family members, despite being senior cardiac professionals at this institution, systematically dismissed her symptoms and refused to participate in post-surgical care coordination. The third slide showed communication records. Voicemails from cardiac surgery left unanswered, emails about anticoagulation management marked as unread, follow-up appointments missed because family members advised against unnecessary cardiac monitoring. Dr. Patricia Williams, Dr. Chin addressed my mother directly, you received 17 urgent communications about your daughter's post-surgical care requirements. Dr. Kevin Williams, you were contacted multiple times about mechanical valve management protocols that prevent thrombosis and stroke. The silence in the conference room was deafening as my family processed the magnitude of their cardiac negligence. Mom's nursing expertise had somehow failed to extend to recognizing heart failure in her own daughter. Kevin's surgical training had been irrelevant when applied to dismissing rather than treating cardiac emergencies. Dr. Mitchell delivered the final assessment. Cardiac professionals who ignore documented heart failure in their own family members while maintaining licenses to treat cardiac patients represent a danger to patient safety. Your clinical judgment has fallen below acceptable standards for cardiovascular practice. The medical board investigation that would determine their professional futures was already underway. 10 months later, I received my annual echocardiogram results showing excellent mechanical valve function with no complications. Dr. Mitchell had successfully performed the emergency surgery that my family had delayed through months of cardiac negligence, and my heart function had returned to normal ranges. The mechanical valve clicked steadily, a reminder of survival that my cardiac family had nearly prevented through their professional blind spots. Mom's license to practice cardiac nursing had been revoked after the state nursing board determined that a nurse who ignored heart failure symptoms in her own daughter posed an unacceptable risk to cardiac patients. Her 20-year career managing cardiac ICU protocols had ended when supervisors learned she'd dismissed emergency valve replacement as routine maintenance. Kevin's cardiothoracic surgery residency had been terminated when the program director reviewed his complete failure to recognize cardiac pathology in a family member. His surgical training was suspended pending comprehensive evaluation of his clinical judgment capabilities. The cardiac surgery career he'd planned was over before it began. They'd moved to a small apartment across town, their medical careers permanently damaged by their inability to apply cardiac expertise to family situations. The respect they'd commanded in cardiovascular circles was replaced by cautionary tales about professional negligence disguised as family dynamics. I'd returned to my work as a biomedical engineer, where I now designed monitoring systems for mechanical valve patients. My experience had become valuable data for understanding how medical professionals sometimes fail their own families while successfully treating strangers. The best cardiac advice I'd received was learning that medical expertise means nothing without medical compassion applied equally to family and patients. Real medical professionals don't distinguish between the hearts they're paid to save and the hearts they're supposed to love. My mechanical valve kept perfect time, a rhythm of survival that my cardiac family had almost silenced.